actually going over case studies of 5 of our actual patients. And I did not pick the perfect ones. I picked, some challenges and things so that we have opportunity to talk about it. I am going to talk about mastering a consult. I also have a business background. That's what I started out in. And I've noticed, and I mean, even for me, I feel like selling can be a bit hard, but when we have our own business, we have to be able to sell. So I'll talk about ways that I have found very successful. This is actually how we train our providers. So I think you'll find it really helpful. And then depending on if we have time, then I'm going to go into testing your knowledge with some open-ended questions, and I'd love for you to jump on and answer them. Okay. So I feel like I need to minimize my screen stuff here. It's a little too distracting. Okay, so here is our first person. And I would say, this is a pretty typical sort of person that you would think would be on a GLP. So she is a 40-year-old female. She came to us as a pre-diabetic, diagnosed with PCOS, and on a low dose statin. You can see what she's been doing here. We always ask before they start, and then, bi-weekly we ask what they're eating as well. But this is nice to see. So initially when she came in, she was eating frosted mini wheats with milk, coleslaw, Italian sausage on a bun, onion, peppers, marinara. She was having a regular Dr. Pepper, water, grapes, and watermelon. And she came to just saying that she is always hungry, and, can't help but graze and eat throughout the day. She was even doing some really good things. She was on supplements prior to our clinic and things that I would recommend for PCOS. So inositol, berberine, NAC, and then she was on magnesium. She was dealing with constipation. So within 2 weeks, so this is on that really low dose at 0.25, she reported only being hungry at meals. Just that alone, from going from constant hunger, even right after eating, to only hungry at meals is like such a huge win. We asked their compliance level, and she's consistently only following 50%. So this is going back to what we recommend as far as diet goes. So you might have to go back and look at our diet plan a little bit more, but she says only 50%. And we got her up to a 0.75 milligram dose. So 2.5 is what all of the testing has been, all the research has been done on. That's that top dose. So hopefully you can see this okay. I did this week give you guys full page slides. I got that request. So hopefully you are able to see this. I know it's still a little bit small, but you can see here things I really look at. The visceral fat went from 20 down to 15. And I should say this is her on it first. What do I have up here? Here is a screen, 6 months on semaglutide. So she went from visceral fat, and remember the 20 on an in-body scale is the highest it goes. So we don't actually know how much higher it actually is, but she went from that highest range down to 15. And then you can see over here, her weight went from 211 to 171. You can see there is some decrease in skeletal muscle mass. So if you're unfamiliar with an in-body, this grayed out area right in the middle here, this is like the sweet spot. Obviously, having more skeletal muscle mass is okay, but you can see, so she was a little bit above the average here, and then she came down right into the middle average. So you can see by following the diet only 50%, we're still having some issues here. Anytime we see any loss in skeletal muscle, every single time we are talking about getting more protein. We are always stressing, and are you able to absorb it? Are there other reasons that your skeletal muscle mass is going down? For the most part, it has to do with they're not hungry, they're not eating enough. Um, I know Sherry talked about this last week, Karen, about the marbling of fat in the muscle. I do think there's some of that. I mean, when you look at, so like if you look at lean body mass here, part of that is total body water. So when you look at like 83.6 down to 76.1, some of that is, that inflammatory holding on extra water. So it is a little bit deceiving when you're looking at, the lean body mass, when you're looking at skeletal muscle mass, because I agree. I think there is some of that marbling too. So it's not 100%, but I will tell you, we have people that have kept exactly the same amount of muscle mass from start to finish. So is it them gaining muscle? Potentially, because they've changed their exercise and diet habits. So yes, that could be the case. No matter what, though, if we see it go down, and we're seeing people every 2 weeks to begin with, and then monthly after a while, we are talking about it. We're stressing the importance and continuing to like talk about that. I think one really nice thing that people like numbers. So when you look at this basal metabolic rate, she started at 1485 and she's down to 1388. And one of the big calculation, or the main calculation piece, is that skeletal muscle mass. So when people see, oh, I get less calories to maintain my weight, they don't like to see that either. So besides the fact that she all of a sudden has no hunger, look at her GI issues, how they've changed. So she went from 21 as a score down to 5. She is still dealing with constipation. That could be partially due to the medication, but it's probably due to past or her current like gut issues. But you can see all the other things. Her bloating is pretty much gone. No more diarrhea. Her nausea even came down, even though, the medicine potentially can cause that. So I think the fact, like her lifestyle, just how she feels is so much better, and significant weight loss. Okay, so Abby's asking, it is really expensive for an in-body. Are there any suggestions on checking fat percentage without a scale like that? So so we have remote patients as well, and there are in-body like home scales that are pretty accurate. We've had people purchase them. They're like $200 or $300, so it would be an investment on the patient's part, but that could be something that you could utilize to see what they're doing. I've also asked patients that are somewhere else that are not willing to buy one of those, like go to a local gym. You can search up where InBody is and go get an InBody for like $25 and send it to me. So that could be an option. Oh yeah. Okay. So Karen says the same thing. If you go to InBody, you can search near me. Usually costs 30. She's said 35 per scan. So that would be my suggestion, either if they want to scale or go somewhere that has an InBody. So this is our first patient. Our next one is a 24-year-old female who came in as a vegetarian, all processed diet. So you can see she put on her intake form, and people usually, lie to some extent about this. And she was willing to just share honestly, which was great. But it's a place to start. So regular Coke, candy, ice cream was what she put in there. Her goal was to lose 40 pounds. She was 7 months with us so far on semaglutide. She was on the 1 milligram dose. So again, a fairly low dose. At week 2, when she came in, here is what our provider noted. She is very pleased, excited. She feels less bloated and has more energy already. She started to eat chicken. We did talk about the importance of protein, and with her already having low skeletal muscle mass, we did talk about that. She didn't eat much along this whole process, but at least she's tried incorporating some of it. She's making better choices. She's starting to plan ahead and prep. Her craving and food noise are gone just on the first 2 weeks on that 0.25 milligram. She started swimming. And so then because she was doing so well, we kept her at that same low dose. There's no reason to go up if the patient is doing well. So then you can look, and we find a lot of disconnect. So she also reports 50% compliance. So there's only so much, I mean, we cannot force them to do these things, right? So all we can do is identify what they are doing, try to help them make changes, et cetera. But I like to look at this other piece. So on our reporting, we asked them if they're constipated, and she put a 0 for it. But then we also asked how many bowel movements she was having during the week, and she reported only 2 to 3 per week. So it is nuanced. It's really important how you're asking things on those symptom assessments or the questions you're asking them in person, because a lot of times if someone's been constipated their whole life, they think it's normal, and that's not constipation. So asking in different ways is really helpful. So because she only followed 50% of the diet, you can see she went from 55 pounds of skeletal muscle mass to 52 to 53 to 53 to 51 to 49, 49, 49. So you can see probably the interventions of certain sessions that got her motivated in doing things and then slipped back into old ways. So when you look at her form here as well, her InBody, you can see significant changes, even though she was only following 50%. When you look up at that metabolic piece of visceral fat, she went from 18 down to 13, really significant. If you look at her actual dry lean mass, it went from 27 to 25. So you can see, look at all this body water change. So 73.6 down to 67. And this is not, I took out the section at the bottom of extracellular versus intracellular, so you can see, but she went from being very inflamed with her diet to taking that inflammation away. So her total body water came down significantly. So you can see too, weight went from 176 down to 147. So another really great story. But again, when they're not following the recommendations, it's you see some of that skeletal mass going down. This was actually one of my patients. She is a 75-year-old woman that came in on thyroid medication. She had been on semaglutide at another location before us, and she no longer could tolerate it and was not able to lose weight anymore on it. So when we looked at her symptom assessment, I saw all of these GI issues. So I was able to convince her, and she wanted actually to do the right thing. And she knew just taking the medicine wasn't going to work. So we started out with a GI map. I saw low commensals. She had a parasite. In her health history, she had said she had her gallbladder removed years ago. And then there was also some overgrowth. So on the GI map, there are markers that you can kind of see, like, would this person be good for a food sensitivity test? And all of her symptoms were similar to what food sensitivities present like. So then she also did the MRT. I worked with her for about 4 months on her gut health. You can see the supplements based on her GI map that I recommended. She was doing GI Revive, which is a gut lining supplement. Restore Flora and Orthobiotic. If patients are willing to do a couple supplements, I like to do 2 different probiotics. She was on the Biocidin for the parasite and some of the overgrowth. I gave Histaid. I cannot tell you how many patients with leaky gut or low commensals have histamine issues. And if those are not addressed, it really can be hard to get people to a better place. So Histaid is different nutrients that are helpful at flushing out excess histamine. And then I gave her the liver gallbladder complex to help replace she doesn't have the gallbladder. So her GI issues originally, diarrhea significantly every day, heartburn, bloating, gas, the histamine stuff I talked about, joint pain, really bad, headaches. She got sick often, and bad ringing in her ears. So after about 4 months, she was feeling really good and then wanted to start on GLP. We started her on tirzepatide right away. She had asked specifically, she's like, I've done semaglutide. I want to try something different. So we put her on tirzepatide, and all of her GI symptoms, but none of them came back. I was kind of curious, when she started a GLP, if anything would present. She feels amazing, no issues whatsoever. I will say I kept her on Megaspore. I kept her on the Hista Aid, the liver gallbladder complex, and then I put her on a multivitamin. And you can see over here, hopefully you can see this as well. Her skeletal mass started at 52.5 and it stayed at 52. She is somebody that's 100% compliant. I love those patients that are willing to do that. Her visceral went from 19 to 15. I mean, just a perfect case in point of starting with the gut, doing what some of that foundational stuff, and how much that can make a difference. So that's her. And another, like, you're never too young or too old to make some changes. Okay, so this person, she is a 63-year-old who lost weight on semaglutide and kept it off afterwards. We try to keep up with our patients. We ask them to check in. Some of them, if they're doing great, they won't come back and check in with us. This is one that did. And we actually have a testimonial video on YouTube about this patient. She came in, she's 63. She was on progesterone cream, and her biggest thing was she was binging at night. And she had said, like, slow weight gain over the last 10 years, got too relaxed with her diet, a lot of social things, and eating out. She also was 100% compliant. She would follow the diet to a T. She would get daily movement in. And this is some of the progress that she noted along the way. So already by week 2, increased energy, improved sleep, hunger suppressed. Week 4, she felt her belly slimming down and she started reading food labels more closely. So see how you get that quick win, and that is often super helpful for weight management patients. They need some sort of a quick win. And then you can start layering in the changes. So reading those food labels. So that'll help her long term. When we upped her to her 0.75 milligram dose, that's when she noticed some constipation. So we upped her magnesium. We talked about increasing fiber. She did those things. Things got better. So then you can see here hers. She went from 185 to 153. Her visceral went from 16 to 10. And we remember we want that 10 or under ideally for metabolic health. You can see her muscle mass really decreased very minimally as well. So 59.7 down to 57.8. So essentially, we would consider that maintaining. And you just see like all the pounds of fat specifically that she lost, 76.5 down to 49.4. So she's somebody, like I said, that we followed along the way. We put at the end of each program, we put people on a maintenance plan. Sherry's going to be sharing that next week more. A lot of times it's very similar to what they're on now. But if their metabolic health has changed, if their visceral fat is under 10, if their labs look good, we do like to expand the diet a little bit more. So that's something we talk about at that maintenance visit. What we did with her is prescribed a vial, and she slowly weaned herself down and off from the 0.75 where she was at. 6 months later, she did come back to us. You can see up at the top here, she gained a little bit back, but she had a foot injury and surgery and was inactive for several months. So she wanted to just get back on a low dose and get back to where she was. So life happens, and it's nice to know, and these people know they have this resource and a way of coming back and not using it as a fix-all, but as a support when they need it. Okay. So we do have way more women than we do men, but I do have one male patient here for you. And I don't know about you, but what we find, or what I specifically find, is if you tell a male what to do, they'll do it, as far as like the food, as far as the movement, more water. So essentially with him, he knew he just wasn't doing a good job and he needed the accountability piece. So every single time we worked on resistance training, hydration, and finding ways to clean up the diet. And that was it. And you can see he stayed only on a 0.5 milligram dose. He was doing really well with that. Like I said, every time we talked about those goals, he was consistently doing his resistance training. He would mess up on diet a bit. There were weeks where what he reported, it was only about 600 calories in a day. He didn't have the hunger. So you can see over time, and I put the whole one in here so you can see the trending here at the bottom. You can see how he came down in muscle mass, specifically in the beginning. He was not eating enough food at all. So he was losing some muscle mass here. He came back up, came down, came back up. So it's constantly something we have to talk about with patients because they just don't get those hunger cues. You can see at the end, his visceral came down to 9, which was amazing. And this down here, I wanted to just show you. So like, we use practice better in recent activity. This is what we do as the recent activity every time. We change up providers on who sees people each week. So this is a really nice snapshot for us to say, like, where are they currently at, or where were they at last session? So we have their starting weight, their current last session's weight, total weight loss, and weight loss this time. When we do the next in-body, we look at the trending of visceral fat. We always pay attention to symptom score, and we look at what's happened with muscle mass. So these are our key pieces and things that we are looking at quick glance that are super important as we're taking care of these patients. Okay. So those were the 5 different patients. Hopefully it was helpful just to kind of see and walk through some different scenarios that were not perfect ones, but how we work with them, how we manage them, and why looking at those metrics and following them in that way are so important. So these are some key takeaways that I think are important. You want to catch it quick and stress it before the muscle loss happens. So I don't know if you've noticed, but when I was putting all these on here, I was, looking at different trends, and I noticed the first 2 weeks to the first month, that is when the biggest loss in muscle would happen. We say it to them, we talk about how important it is. They've seen it out on social media, and yet, it's hard to get away from, oh, if I eat less, I'm going to lose more. So maybe even showing them data. And, I think now that I think about it, I want to put something together for our patients to, in their face, say, this is what happens when you don't follow. So trying to stress to them right away is key. Low dose works so well. So you saw we have people stay anywhere typically from 0.5 milligrams to 1 milligram. Sometimes it's lower, sometimes it's a little higher, but we stay right in that space. Healing the gut can really work wonders for quicker weight loss, more effective weight loss, and avoiding symptoms with these GLPs. Maintaining and losing afterward is possible. It's about maintaining those habits and making sure they're metabolically healthy when they're going off of them, so that they don't go back, don't have all that food noise, don't deal with all those same things that they had when they came in. And this is so great at removing food noise. If your patient comes in with cravings, food noise, constant hunger, or they have labs and there's insulin resistance, this is just such a game changer for these people. All right, those were the case studies. If there's any questions, let me know. Otherwise, I'm going to move into an overview of a consult. So we're completely changing gears here, but such an important piece when you are trying to attract patients. That consult obviously is the piece where they're going to say yes or no. So it's really important to be prepared for your consult, and having a really good intake form is the first step. We also do an intro video. We send to them, we have it on YouTube. We send it to them ahead of time so that they have some idea before coming in what we do, who we are. So if they're the people that really like a lot of detail, they love having this video. And then it cuts down on the amount of time we have to talk and say the same things also. The greeting is so important, the right questions in the beginning set the stage. The mission and how we're unique is really important. When we discuss available programs, I'll go into this in another slide, but it's really important you don't overwhelm them with too much information. It's important to share what we think is best, and then also acknowledge what the patient's most interested in and come to an agreement together. We talk about the cost, check out their response, and then we make the final recommendation. So, like I said, what you have on your form is really important. The form can actually be a way for them to explore a little bit more too about, like, for example, why did they decide to schedule the consult today? Sometimes, they don't even stop to think about those things, and it helps move them towards being ready to make a change. So, reviewing their health history, making sure goals align with who we are. The symptom assessment's important just to make sure you choose the right program. Sometimes there are missing pieces on the intake form, things that you want to ask. So I make note of that before I walk in with them. So it's really important to have that plan prior to taking the patient into a consult. Hopefully you know this already too, but that smile, that open welcome, it's scary for a lot of patients to come in and talk about weight loss because they've failed before, or they have the belief that, it's just them, or they don't have willpower. They've been told by their doctor to eat less and exercise more, and it's not working for them, and there's shame and all of that around there. So if you can make them feel comfortable right off the bat, that's a huge piece of it. I like to always ask where they heard about us so that we know where we're getting referrals from. It's important to set a structure of the consult and set those boundaries. I'm sure I'm not the only one, but you have that patient or that person that comes in that, is there for 40 minutes and you cannot get them to stop talking. So the more you can set those boundaries ahead of time, the better. Thanking them for completing that information. They like to also know that you prepared for the session. Giving them a little time to talk, but not too much. So asking them really specific questions are really important. And then explaining the difference of how we are different. I think giving them the why of not going to the competitor is important too. We do get patients that shop around a lot because they're trying to find the right fit for themselves. So we do talk about that difference. We talk about how weight loss is multifactorial. The body is complex. We like to do testing to get to root issues, and that we customize programs to them. People really like to hear all of those things. When we talk about programs, here's a couple other things that they really like to hear: that we're providing weekly or bi-weekly support sessions. They don't want to feel alone, and most have failed in the past and want that comfort of having the accountability. And then that we provide maintenance and support at the end. It's crazy. A lot of people don't end up utilizing it, but all of them want that or think they want that in the beginning. So talking about how you will help them, because weight loss is one piece of it, but maintaining weight can be even harder. And I also like to talk about highlighting the options, the negatives and the positives. So I like to distinguish the differences. Like, this is a very strict program. This is a very flexible program. Like, easy words to help them put these programs into buckets. That tends to help quite a bit. and explaining, knowing them, using some of their labs, using some of their supplements, using their experiences to explain why this program will work for them. So anytime you can bring it back to them or something they said in the consult, that is really helpful. This is also important. So if you confuse a patient and give them too much, they're not going to purchase in, they're not going to say yes, because now you've confused them. They don't know where to go next or what to do. You have to give them a very clear solution. So only discussing one or two programs, you might give an overview in general. We use Prezi for our consult, and I like it because we can zoom in and out of different areas instead of a presentation like this. That's, 1, 2, 3, 4. We're zooming in and out of different areas depending on what people talk about or where we go with things, so that we're not overwhelming them with it all. I like to stop and ask if they have questions or concerns, especially if they look confused, for example. Okay, so Prezi, it's another platform that's kind of like PowerPoint, but it's a more dynamic sort of way to have PowerPoint. So there's a screen like this, and you have slides, but like if I would click on give them solutions, it would zoom into a whole nother page. Or I could have over here this program or that program, and you can go in and out of the different ones. So it creates more of a conversation and more of a dynamic interaction. I will tell you, it is not as easy to use as PowerPoint. It definitely takes some learning with all of that. I don't feel like proficient at it, but it has been really helpful. Okay, so I think here too, ask them at this point, like, are you leaning towards any of the programs? Do you want to hear any more about a specific program, so that I know from them where to lean in and talk more about? I want to give them a minute to think too. Some of them are like quick, like, yes, let's do this. I know I want this. And you can tell the other people that are hesitant. So sometimes even giving them the space to say, do you just need a minute to think about it? I can step out and you can review a handout. Another thing we do is we provide a program handout right when they walk in the waiting room. So they're looking at that before we take them back, so that they're having some exposure to our programs as well ahead of time. Because that can be the really confusing part, and that can overwhelm them. They want to make the right choice. So delivering your recommendation with confidence is really important, and affirming that it's a good choice for them because of X, Y, and Z. Even going back to explaining that, or letting them know, yes, I understand this is an investment. It's going to be a commitment and a cost. We want to make this doable for you. So helping them through the thought process of how they're going to pay for it, taking them to that next step to say yes. So we do offer payment plans for some of our programs. Sometimes you have to dig deeper to their motivations. So you can see that they're like hesitant. They're people that have to like think through things more. So you want to get them talking a little bit more. It's kind of like coaching, but it's coaching them through the sale. Are there any more details you want to know about this program? Sometimes they want to see the actual diet plan. So we have a 1-page where it would be like, we don't let them leave with it, but we'll show them the diet plan. If they're hesitant, we'll say, all right, what's holding you back? And it's usually having to do either with the cost, the fear of the structure potentially of it, them making an actual commitment. Maybe they're not ready yet. So then sometimes you can get them there, talking to them about maybe why health is a priority, or if they're not ready to commit, why it's not their priority. Helping them envision or get deeper to their whys. Is it about having more energy? A lot of people come in and say they want to be able to play with their grandkids and they aren't able to move or get on the floor with them anymore. So helping them go into that why, and then letting them know too, like if they don't do anything today, what's it going to be like for them 6 months from now? Are they going to be in a worse place? Are they going to be in the exact same place? They usually come to you because they're not happy where they're at right now. So getting them to talk that out, I think, is really important. Sometimes you have to, they still haven't opened up to you. So making something personal, oh yeah, I've tried this program, or this is what our patient, we have a lot of patients in a similar situation as you, helping them know that they're not alone and affirming those changes. Not that, this one can be a touchy thing, but some just are very open and honest about, like, I don't have the money for it. How would I do this? And they start talking about the budget and everything. And sometimes it's just that mindset of like, okay, well, you do go to Starbucks every day. How much are you spending on that? Would you reallocate the money towards your health? That sort of thing. Like some people do really well with talking through this and their budget. So just another idea. Sometimes we will use a final tactic, like offering a discount. So if they pay in full today, or if they commit and put something down, we'll give them $50 off or something like that. We usually don't bring that out unless they are wishy-washy at the very end and they want to, and you can tell they do, but they're just nervous to say yes. And then some people just straight out ask, are there any discounts? Because everybody likes a sale. So that's where we will do that sometimes. We try to get them started as soon as possible. So keeping availability on your schedule for new starts is really helpful, because usually, specifically with weight loss, they want to get started now. So try to get them started as soon as possible. Get a deposit if you can't start them right away, so that they've committed. That's their yes. If they walk out without doing anything, maybe give them something. So, while you think about it, let me give you this booklet on detoxification and what you can do right now while you think about it. Or here's one of our free programs online, something to give them value right off the bat. And then they'll continue to think about you. And if they do well, they're more likely to say yes. So that is a consult in a nutshell. Does anybody have questions on that? Otherwise, I'm going to move into our review questions. And I would really appreciate if you guys would be willing to go off of mute and share if you have the answer or how you would answer some of these questions. So the first one, what are the potential benefits and drawbacks of following a high protein diet while on these GLPs? Does anyone have an idea on this? I know this was back to week 2.
Erica, this is Leslie. I guess I don't know any drawbacks. I can't remember that. I don't think of any drawbacks when I think of, I don't know how high protein is, but most people aren't at the threshold where I see it as a drawback. But obviously the benefits of maintaining muscle mass is the big one that comes to my mind.
Okay, thank you. Yeah, so okay, so someone's saying, yeah, maintaining muscle mass, constipation, nausea, meat aversion with the medications. So some people, if they don't have the right acidity in the stomach, the right HCl, they have a hard time digesting proteins. And some people really are going too high. I know a lot of people on GLPs probably won't be, but that high protein load, harder to digest. So that would be the only drawback. When we say high protein, you still want the balanced diet, right? So you don't want to just be focusing on protein. And I think that could be a message that gets wrongly discussed, or like a patient will see it that way when that's not what we're actually meaning. How might intermittent fasting complement or conflict with the GLP treatments? Does anybody want to talk about intermittent fasting and their thoughts on that?
I mean, I think
Hi.
there could be,
Oh,
go ahead,
go
somebody
ahead.
else can go.
No. You go ahead. You go ahead.
Well, I guess I'm just thinking about it and, more so about like, I mean, it could complement it because you're giving a very specific time window, um, and a very structured plan of how to get things in. Um, Trying to build that up autophagy that's going to help, with inflammation, going to help with, weight loss, things like that. I think there's challenges with it is to can you actually get that amount of food in a certain window because of the slowed gastric motility? Can you do as much nutrient dense food in a short duration of time?
Yeah, excellent. That's exactly, I think that's the hardest piece for people that are dealing with some of the GI issues, that intermittent fasting can be really hard to fit it in. It's so easy to intermittent fast when you don't have hunger. So they might take it a little too far. And the only type of patient without GLP, even that I get very nervous with intermittent fasting is ones that will take it too far, super A type personality. You can see adrenal issues. All we're doing is stressing the body more. So that would be the only time. I know that's separate from the GLP, but yeah, there's a lot of benefits to it, but it's making sure they're getting enough in still. Um, the labs one is kind of hard to, it's so broad. This would just, I guess, be, well, Sherry actually next week is going to go over our metabolic health panel. I know she touched on it really briefly last week, but we're going to talk about how we use it and how we translate it to diet with assessment for our patients. So I think we'll save that question more for that. This next one, though, how would you explain the importance of gut health to a patient and its connection to weight loss? So I'd be interested. So I know not everybody uses stool testing. If you don't use stool testing, how do you talk about gut health? What do you do for your patient? Or if you do use stool testing, what's your approach with that? I'd be curious to hear from some of you.
Sorry, I have a bite of food in my mouth, but I was gonna say, I don't use testing. I mean, I could, but I don't really use it frequently.
Okay.
But one of the things I talk about is like a lot of those nutrient dense foods like vegetables, you're going to have trouble digesting those if you have poor gut health. And you're not going to have great bowel movements, which can lead you to feel bloated and backed up, which then makes you feel heavier. And then sometimes I know that if I'm feeling that way, I'm going to lean into those negative food choices because you hit what I call like F it mode when you're just like, well, I already feel gross, so I might as well just eat, something that's easy on the stomach, like a cookie or, something like that. So I think that that's kind of one thing that you can talk about, that bowel movement promotes detoxification and getting rid of some of those things. And if we're not having adequate amounts of stool passing through, then that's a problem.
Yeah, definitely. I'm curious, if do you put them on any sort of supplements right off the bat, or do you just try to adjust the diet?
I am a really big fan of psyllium husk and magnesium oxide to kind of help move things through gently. Um, I try to avoid things like, Miralax, but I really like magnesium oxide to start. And then if stool is too loose, we can kind of titrate that up or down depending on what they need. So that's kind of my first go-to. And then with testing, that might be able to show like, oh, well, our balance or microbiome is way off. Maybe we need to add in a specific probiotic or something. And are you eating enough food that's actually going to push the food, push your food through your system? If you just aren't eating at all. I have one client in particular that I'm thinking of that did tirzepatide, and she ended up losing a lot of weight, but now her gut is just totally destroyed. And I think it's because she wasn't working with anybody while she was taking the medication and she did not eat enough. So things really became out of balance and she's really suffering right now.
I'm curious. So what kind of symptoms does she have now?
So she says basically she can't eat meat. Meat like disgusts her. So we've talked a lot about low stomach acid and how she can bring that up. Lots of bloating, extreme fatigue. I think she might actually have SIBO, but doesn't want to do the testing right now. And she's like, taking Miralax every single day, lots of it. She's not consistent. She's still not eating very much. I think her metabolism has really adapted to that low intake. And so that's why
Mhm.
she's feeling so tired, so run down. Her appetite's really poor, and she just doesn't prioritize herself at all. Like, she's a mom of 3 kids, really busy, and just like doesn't eat all day and then running around with the kids at night. So
Yeah.
she still has a lot to work on.
Yeah, it's interesting. We've had a couple patients like um, go towards that SIBO route because the slowed motility, it allows that
Hmm.
food to sit there longer. It's feeding the bad bacteria. You're not digesting well, not eating enough food, and probably not all those good fibers and healthy things. So that's, yeah, your patient's not alone in that, unfortunately, and just even more reason why we need us dietitians working with these patients while they're on these medications.
Absolutely. I think that it's something that they don't, it's kind of like that weight might be the number one thing that they're concerned about. And then they're kind of willing to lose the weight at any cost, even if it means kind of sacrificing comfort, but they're not realizing that they're setting themselves up for long term some really yucky stuff because like she's saying, I'm so happy with my weight now. My weight really isn't changing, but I look like I'm pregnant because I'm so bloated all the time. I don't feel good in my clothes. And that does drive, I mean, I personally think it really drives bad food choices when you are feeling that way.
Yes, you go to comfort foods,
Yeah.
things that feel good, because there's a lot of foods that don't feel good. Then I was going to say the same thing. I have a lot of SIBO patients that have body image issues. It's just that bloating in the stomach area that they feel so
Hmm.
uncomfortable with.
And it is painful. I mean, it's like
Yeah.
I've had SIBO and it's very uncomfortable and you do feel very low energy and just tough. But I think too that this is like something to be on the lookout with things like that because that slowed
Yeah.
motility makes a difference. I don't know. I haven't really added a lot of motility agent for people, but I didn't know if that's something that um is helpful and if it's also is it like counteracting what we're trying to do, we want to have a little bit slower so we feel full longer.
Mhm.
Would a motility agent offset that to the point that they're not going to get good results?
That's a good question. We haven't found that. We will add prokinetics for specific patients that already come in with what we can tell is motility issue. So we've thought the
Hmm.
same thing. Usually we'll do it, either we'll have them take like 2 capsules like before bedtime, or we have them take one at the end of each meal, and it helps.
Okay.
So, because a lot of times those patients that already have those motility issues, the satiety or whatever, that's not the problem. It's more
Yeah.
those other pieces of the insulin resistance, or the hunger signaling or whatever. So yeah,
Yeah,
we do
absolutely.
use that. I like to use sun fiber. Sun fiber tends to be well tolerated with SIBO patients. So that could be another fiber issue or another fiber option if you feel like they're not tolerating a different one you're suggesting. So just another thought. Great discussion. Thank you for sharing. I do have a bit more. We have like 10 minutes. Okay. So this was on the week, that one week that I was talking about behavior change and all of that. How do you help your patient who's struggling with feeling deprived, they're self-sabotaging while they're on GLP medications? Who wants to take that one?
sorry to chime in again, but I think
Okay.
this is like a big mindset issue too. Like something where you have to be saying, one of the things that I recommend a lot of times is like, let's track your food, whether it's through like the Practice Better photo journaling, or if you like to be more specific, you can do like some macro tracking. But I think even seeing that and understanding that like I am getting enough and things are different and what I was doing before was not working. So I need to make a change. You know, if I'm committed to like making this work and going on the medication, photo journaling to me doesn't seem like asking too much. And I think that can really show you what you're eating. And I always call it implementing the pause, like that moment of like, okay, how bad do I want this food? Am I willing to take a picture of it? I think that just that moment truly, like even 10 seconds of thinking about it can make a big difference of like, okay, do I want to do this? And a lot of future self work of like, what do I want to get out of this process? Why am I doing this? What is my future self going to say based on this decision that I'm making in the moment?
Yeah. It's crazy to me how many people put so much money into these medications, and some of them put them in thinking, okay, I've put my work in with this money, now it should work for me. And when it doesn't, they'll put blame on the medication, they'll put blame on us, until you can turn that story around and get them to realize it's, their deprivation, their self-sabotage, whatever. I like the picture thing too, because that is not too much to ask. Some people say, I don't like tracking, I get too much in my head and all that. I get that, because I'm actually the same way. But that taking just that picture, when they aren't willing to do that, it's because they don't want to show you what they're putting in their mouth.
Oh yeah, absolutely. I have another client who's been on, she's gone all the way up to the full dose of Ozempic, and then, or I'm sorry, she was on Wegovy. Now she switched to Zepbound. She's on the highest dose. She's lost 5 pounds in like 2 years. And I'm like, this is not a medication issue. This is something that you need to, look at what you're doing. Really look at it and decide how much effort you're willing to put in, because this is just a tool and you have to actually work to get to this point that your intake is modified from the drug, not vice versa. Kind of just eating whatever you want and expecting it to work without doing that. And I think that this could be something that when somebody has been out of tune with their hunger and fullness cues for so long, you have to really work with them to be like, okay, are you actually hungry, or what's the feeling that you're feeling? Doing journaling, things like that, talking about your emotion and things that might be helpful for someone who's kind of self-sabotaging as well.
Yeah, those are great ideas. That to me, wow, like this patient was willing to get all the way up to the top dose on 2 different kind of medications and still hasn't seen the weight loss. Like, when does that click for her or him?
I don't know. It's a her, and I honestly like, and I've tried to discontinue our visits several times because she cancels a lot and doesn't show up, and I always charge her no-show fees, but she still is like, no, it makes me accountable. And I'm like, I don't, is it? I don't know. But I think it is just like, she didn't know what it felt like to be hungry or full before. And so that it really isn't a stopping point of like, oh, I'm not hungry. It's more of just like a state of being. It doesn't affect what she eats at all.
Yeah, I'm really curious why she's doing it then, if that's like her way of doing something, or some people, they'll be upset about losing a half a pound, or over the holidays maintaining. But I always try to flip that. And for some people, maintaining is a win. So I don't know if that's for that patient, if before they were constantly gaining, or if this is just she hasn't figured out the right thing for her.
I think she has some other stuff going on too. Like she sleeps a lot. I think she might have chronic fatigue syndrome or fibromyalgia or something along those lines. But I'm actually honestly like surprised that her provider hasn't said like, let's discontinue this. It's obviously not working right now.
Yeah, I know. And sometimes it takes you saying the same thing 10 times before they hear it, or saying it differently before they hear it in a way, or multiple providers saying the same thing. I try to, when we have difficult patients, try not to give up on them. I know that's not what you're saying you're doing, but it's coming in with the best intention and knowing they have a lot going on and trying every time. You might sound like a broken record, and it can get frustrating for those sessions for sure. But yeah, I feel for you on that one.
Thank you.
Okay, maybe one more. Let's see here. What supplements do you like to recommend for your GLP patients? I feel like we've talked about this a lot, but I haven't heard from a lot of you. Are there key supplements you put your patients on that are on GLPs?
Yeah, I mean, I always do gut restoration stuff for sure. So I always do like a TGR protocol for microbiome, or I do a colostrum, mucosal support, gut healing support, kind of at the same time. Yeah, and then depending upon symptoms, right? Like if it's a reflux issue, a GERD issue, if it's constipation, if it's, where is the slow motility manifesting? Taking care of that. I'm a huge magnesium citrate fan. I like citrate better for some reason. And so I use that a lot. I use Poop Doc. It's a great product for high dose, for people who need high dose. And then and then it's otherwise it's based on digestion labs, anything else that might be of role. And then I know, like with Sherry, we were talking about like support supplements with the GLP. So like, do they need a berberine in addition, or which might have some antimicrobial effect, which could be helpful, or to help move things along, different things like that. I've considered.
Nice. Yeah, we need to focus on the GI stuff and make sure these patients are not moving to the SIBO category or anything like that, that they're actually digesting their foods. I really like those broken down amino acids. I think that helping make it easier for them to get more protein in during the GLP treatment is helpful. I also use magnesium citrate. I know, oxide and citrate are both really good. I just have never gone that route. I've always just stuck with the citrate. Yeah, those were all really good suggestions. And it's really unique per person when you look at the GI piece of it. Okay, so we are out of time. I just want to summarize quick. GLPs can fit all shapes, sizes, lifestyle, ages, motivation, education. I hope our case studies here today showed you a wide variety of patients. Continue to focus on that intake and protein, ask in different ways. When it comes to the consult, that confidence is everything. Listen closely, make sure they feel heard, and give your expert recommendation. Make sure you practice your consult. If you're trying something new or having a new service, that your language and how you talk about it, recording yourself. I know those things can be hard to hear, but they're really helpful. And then I have to put the plug in, charge what you're worth. We don't, as dietitians, we spend so much time outside of our sessions supporting our patients. So always keep that in mind and charge what you're worth. So when you look at this and how you're going to implement it, how are you going to structure your support? We do bi-weekly and then monthly once patients get going. Can you partner with someone for the medication management? How are you unique? And who's the right client for you? I don't think you should accept every single client. And I know, Kate, you were trying to fire your client. It's like finding that right match, and maybe somebody is better for different people. So keeping that in mind too, you don't have to take absolutely everybody. I am going to include our pre-consult video and what we do post-consult as follow-up, because some people do need that a little extra time to think. So that's everything. Does anybody have any last minute things they want to talk about? I know we're at time now.